All right, so here is the activity code for today. So I'll leave this up here for a little bit so you can all get your CME credit.
You tell me when you want me to move it.
Okay, I will. All right, next slide, please. And here's just more information about getting that CME credit via text. I'll leave this up here for a bit so you all can read that as well. All right, next slide, please. And then here's just information regarding CME transcripts. All right, next slide, please. And then this is just regarding the AAFP credit system. All right, next slide, please. And then this slide just goes over the core competencies. All right, next slide, please. So Dr. Estrada has no financial relationships with ineligible companies to disclose. Next slide, please. All right, Dr. Shi.
All right, so let me do a brief introduction of Dr. Estrada. We're very pleased and honored to have him speak with us today. And I was reading his impressive profiles. So he completed his undergraduate training in Guatemala in 2003. He received a Doctor of Medicine degree in University de San Carlos in his native country, Guatemala. In 2016, completed internal medicine residency training in Albert Einstein College of Medicine in Bronx, New York, followed by a fellowship in pulmonary and critical care here in UT Health San Antonio. That's in 2019. And he's a very active member of many academic societies in pulmonary and critical care. And he currently wears a lot of hats. He's an assistant professor of medicine, specializes in pulmonary and critical care, director of Pulmonary Hypertension Program, as well as medicine thoracic outpatient services from UHS. He also serves as the associate program director for the internal medicine residency program, and also has the clinical educator track, which some of our residents are actually getting training in that track. He's inducted as a fellow of the American College of Chest Physicians in 2022. Finally, he's part of the UTSA College of Business Executive Development Program for the Emerging Health Leaders of 2022 and 2023 cohort. He's board certified in internal medicine, pulmonary disease, and critical care medicine. Without further ado, let's hear the presentation on pulmonary hypertension from Dr. Estrada. Thank you.
Can you hear me well? Great. Thank you for the very kind introduction and the invitation to share a little bit of what I do in pulmonary hypertension. I'm sorry, my voice is a bit raw. I'm a bit under the weather. And I was looking forward to the in-person meeting, but I guess this worked out based on that situation. So I know pulmonary hypertension, it's a very niche specific topic. When I was invited to give this talk, I thought it was very important to discuss what you would see as primary providers or family medicine providers in how to approach the question of pulmonary hypertension. I can only envision that when the topic came up and said pulmonary hypertension, some of you may have felt a little bit of a gut punch and a little bit of a visceral reaction to the topic. So my goal is by the end of this talk today, that reaction is different and that you'll have a better understanding of what to do. So I serve currently as the Pulmonary Hypertension Program Director. I've served this role for the last year now. And that's a program where we see pulmonary hypertension exclusively. And I'll at the end of the conversation, I'll show what this means and how you can access our program in case you were needed. So my objective is to provide a clear and concise information about the need of multidisciplinary care in caring for these patients with pulmonary hypertension. And for that, I want to give you some basics of pulmonary hypertension and why that matters. I'm going to explain what PH is for the non-pulmonary provider, and I'm going to explain also how to get access and what a pulmonary hypertension center is. To start with, I want you to picture the last time you saw a young patient with shortness of breath in clinic or in the hospital, and you really didn't know what to make of it. And at the time, he's like, why is he so short of breath? Is this pulmonary hypertension? Should I start thinking about this? And if so, do I need to start him on therapy, or what testing do I need? And then my goal is I'll provide some clarity and focus to these questions. I'm going to present a case. It's just a case that I've seen in clinic, and we'll come back to this case later in the conversation. So it's a 36-year-old lady with 50-pack history smoker, according to 2019. She also used some drugs in the past, and it also has chronic hepatitis C. When I saw her in 2019, she has progressive shortness of breath, unable to do activities of daily living, multiple ER visits. She's been diagnosed with asthma, quote unquote, and she has now had 20-pound weight loss and some joint pain. Now she comes to me because she's wheelchair bound and is on oxygen. So this is a very sick patient, right? And when you see this patient, you think about a million things that could be going on, but she's a young patient. So we should really start thinking about multiple differential diagnoses. So why is pulmonary hypertension important? Because the prevalence of the pulmonary hypertension is about 1% of global population, and that represents about 79 million people, which is the combined population of Texas, California, and Georgia. More importantly, 10% of this population is above 65 years old. And as we'll see later in the presentation, the concept of pulmonary hypertension has evolved over the last few decades. And it's very important to have a very actualized and updated recognition of pulmonary hypertension. So when it was first discovered, so to speak, or first described in 1951, it took 45 years for the first targeted therapy for pulmonary hypertension. And that was this epoprostenol trial in 1996. But since then, we've had multiple randomized controlled trials. And those multiple randomized controlled trials have given us in the last 20 years a number of good medications, and the 3-year survival rate has increased from 30% to 70%. So as you can tell, it's an explosion of PH advances, both in diagnostic, biomarkers, therapies over the last 10 years, and we expect it to grow even further in the next 10 years. And this is important for you as primary providers because you'll start seeing more pulmonary hypertension in the coming years. So what is it really to the basics of pulmonary hypertension? It's, as you can tell from the diagram on the left side, a normal pulmonary artery has a diameter that's wide enough to accommodate for the blood flow. And what happens to pulmonary hypertension is that diameter starts getting decreased. And the real problem with that decrease is an enlarged right ventricle and the right ventricle hypertrophy that accompanies this. So think about it as, the 410 at 4:30 p.m. that normally your flow, no problems, and all of a sudden that flow gets diminished because there's narrower space. And what really happens is that on the left side, you see what a normal pulmonary artery should look like. It has different layers. It has an intima with endothelium, has a medium with smooth muscles, and then has a layer of adventitia. And that, through the remodeling, the middle part of it and the intima get enlarged. And what really happens is decreased radius. Poiseuille's law, if you go back to physics, this decreased radius increases the pressure, which in turn decreases the flow. And ultimately, what we're really concerned about is the decrease of flow, which in the heart means cardiac output. So a little bit of histology here. I'm not going to be too extensive, but I do want you to notice that there's two elastic lamina. There's an internal and external elastic lamina. In the space in between, it's the part that gets the mostly affected. So there's 4 specific pathobiology markers of pulmonary hypertension. The first one is vasoconstriction, where the smooth muscle just gets constricted through inflammatory mediators. Then there's arterial remodeling, which is the critical part of pulmonary arterial hypertension. Because when you think about vasoconstriction alone, like it happens in systemic hypertension, you use vasodilators and the vasoconstriction relaxes. But with arterial remodeling, vasodilators don't work as well. And that's the challenge with pulmonary hypertension. This all happens through different inflammatory markers, and truthfully through 3 different pathways that we'll review later on in the conversation: endothelin, nitric oxide, and procyclin pathways. And the reason we'll review them is because that's where our medications targets lie. So the 2 other pathobiology lesions are plexiform lesion and thrombotic lesion. And the reason I'm explaining this, the reason it's important for you as primary care providers is because these lesions are not found in other disease states that may cause pulmonary vasoconstriction. So if you find those lesions, it's most likely a person with pulmonary arterial hypertension that needs to go to a pulmonary hypertension center. The plexiform lesion is pathognomonic of pulmonary arterial hypertension. And as you can tell from this slide, there's almost no lumen left. And lastly is we have thrombotic lesions, that you have a thrombus that develops holes within the thrombus, but it narrows the dimension of the vessel as well. So what ends up happening, as I mentioned before, is different changes from scarring, from clots, from thickened walls, congested large vessels that lead to have from a normal pulmonary artery in the medium diagram to a diseased on the right diagram, and in turn increases the resistance, the pressure, and decreases the flow. So this is the basic pathobiology, the basic understanding of pulmonary hypertension. But who sees this pulmonary hypertension patient in practice? Well, you'll be surprised, because even though in the pulmonary hypertension center is all we see, most of you or most of my colleagues in internal medicine and different subspecialties end up seeing these patients as well from different point of views. And we'll talk about how this multidisciplinary approach is very important. So how do we classify pulmonary hypertension? So pulmonary hypertension, as defined as increased pulmonary resistance, has 5 different groups. And I'll go into this a bit more in detail in the future, but I want to explain something very clearly. Pulmonary hypertension is not the same as pulmonary arterial hypertension. Pulmonary hypertension represents increased pressure, increased resistance in pulmonary artery. But when you have pulmonary hypertension that has remodeling of the artery, that's called pulmonary arterial hypertension, or WHO group 1. And it's important too, because therapies that have been designed are usually designed for PAH, but not for the whole pulmonary hypertension world. And it's going to become clear here in a minute. So we have group 1. These can be usually pathic causes, connective tissue disease, portal hypertension, or congenital heart disease. And those can be inherited from genetic mutations, drug or toxins induced, meth being one of the highest ones. Truthfully, before I started doing pulmonary hypertension, I didn't realize so many people use meth, but it's very closely related to meth, the incidence of pulmonary hypertension. And it was first described with this drug called Aminorex, which is a weight loss supplement that was taken in the 1970s. And physicians were noting that these patients, after starting on the drug, were having increased pulmonary pressures, increased shortness of breath. And that's how the pulmonary hypertension concept started developing. And lastly, there are some chemotherapy regimens that can be associated with pulmonary hypertension. Worldwide, schistosomiasis is the most common one in the sub-Saharan Africa and Brazil. And HIV has also been identified as a cause for PAH. This is important because this is the subtype that actually gets therapy for pulmonary hypertension, where therapy is best described. And here we can see our colleagues from rheumatology, gastroenterology, infectious disease being involved. So again, the reason this is important is because either you or one of our colleagues from rheumatology, gastroenterology, and infectious disease may pick these patients first in clinic. And it's important to understand the disease process to know what to do next. The second type, WHO group 2, are related to left heart disease. That's diastolic and systolic heart failure and valve disease. Group 3 is patients who have COPD, ILD mainly, some patients with hypoventilation or high altitude dysfunction. Group 4 are patients who have obstruction in the pulmonary vessels, most commonly through clots, and that is called chronic thromboembolic pulmonary hypertension. If they don't have hypertension, but do have the clots, that's called chronic thromboembolic pulmonary disease. And again, worldwide, group 2 is also important because schistosoma can go into the pulmonary vessels and create physical obstruction. And lastly, we have group 5, which is a miscellaneous group. Sickle cell patients, sarcoidosis patients, metabolic disease, and CKD usually fall into this category. What we call pulmonary vascular disease, what we're referring to is group 1 and group 4. So the purpose of what I'm explaining this to you is not to make it confusing, but rather help you clarify when you call the term pulmonary hypertension, it involves a big umbrella of causes for pulmonary hypertension. When we call pulmonary vascular disease, it involves 2 main causes. And we call pulmonary arterial hypertension, it involves group 1 mainly. So across the world from all groups 1 to 5, it's, as you can tell from the graphs, is mainly between group 2 and group 3. So left heart disease and lung disease. And it's about 90 to 96% of the patients. So when you have a patient in clinic and you have increased shortness of breath and you get an echo and the echo has increased PASP, which we'll talk about in a minute, your chances 9 out of 10 are because of lung disease or heart disease. And this is going to become very important later in the conversation too, because these patients do not need pulmonary vasodilators. They need to be treated for their underlying disease. It's the exception, the 5 to 10% of patients who end up having pulmonary arterial hypertension that should end up in our program, and I can do tailored therapy to them. When in question, the best thing to do is take a look at them. This is what it looks like for group 1 only, pulmonary arterial hypertension. As you can tell here, the majority are from idiopathic causes, connective tissue disease, and congenital heart disease or portal pulmonary hypertension. So what have we talked about so far? There's a high prevalence of pulmonary hypertension, about 1% of global population. There's 4 main mechanisms of pulmonary hypertension and pulmonary remodeling. And there's 5 WHO groups of pulmonary hypertension. Pulmonary hypertension, again, is not the same as pulmonary arterial hypertension. So what is going on now in the pulmonary hypertension world? We're noticing now a paradigm shift. In the past, we used to expect young female patients to start developing symptoms out of nowhere. But now what's going on is that we're seeing patients in the mid-50s, mid-60s, even 80s in clinic to present de novo with pulmonary hypertension. So that change in prevalent age based on this different cohorts in the 1980s, early 2000s, and teens, and the age mean was in 36 range and has moved up to 48 range in just 20 years. Now it's a combination of multiple factors. Number one, we have a better way of diagnosing pulmonary hypertension more consistently, but it's also presenting de novo in older patients now. In this comparative registry in 2013 from the European countries of about 500 patients, this was a prospective registry of 28 centers. And these are newly diagnosed in idiopathic pulmonary arterial hypertension. As you can tell from this graph, a third of them were greater than 65 years old. But why do we care about it? Because the older the patient gets diagnosed at, the worse the survival rate. So we really have to have a high incidence of suspicion on pulmonary hypertension, particularly pulmonary arterial hypertension, as I mentioned just a minute ago, even in elderly patients. Mortality, as I mentioned, increases with age. So in this graph, you can tell the age range increases from the top to the bottom and decreases the cumulative survival of all these patients. Important to notice that the increased mortality in PH patients with comorbidities is going to be always higher regardless of age. The last graph, the one black dotted one, is all these cases with comorbidities. You have someone with comorbidities and you diagnose PAH on, their chance of survival go lower. And this report was from last year from the UK. So these are the comparisons of patients without comorbidities and patients with comorbidities in idiopathic pulmonary hypertension. And their survival at 3 years drops from 70% to 40%. So always important to keep that in mind. From this graph, I want to show you also that there's differences between the idiopathic PAH causes too. So as I mentioned, group 1, and there's multiple causes that can cause that arterial remodeling. If it's a patient with connective tissue disease like scleroderma, their survival is less than if it's a patient with congenital heart disease. Congenital heart disease tends to have the highest survival rates of all the PAH cases. But what happens with group 3 pulmonary hypertension, patients who have lung disease, they actually have the worst survival of them all. There's multiple theories for it. Sometimes because there's a bigger impact in the oxygen demand from lung disease. Of note, the best survival is from group 4, from CTEPH cases. And this is important because we have to, when we see a patient, we're suspecting pulmonary hypertension, we really need to do the work to sort out what kind of pulmonary hypertension this patient has, because that will impact their survival at 3 years, as you can tell here, and longer for different cases. So to review, we have now an older age population. Mortality does increase with that older age, and it's important to keep that in mind. And the more the comorbidities, the higher the mortality rate as well. So I want to pause here a little bit, and I want you to take it all in and realize that pulmonary hypertension, even though an object that you may not manage in your day-to-day activities, is a highly prevalent condition, a condition that leads to high mortality, and we really need to have a high sensitivity to diagnose it. It can sometimes feel like a rabbit hole once you start going into it and you don't know what the next step should be. So I'm going to introduce a little bit of diagnostic concepts to help you guide your diagnostic approach. So this is gentlemen's. Sometimes the patients with pulmonary hypertension may not realize they're short of breath until you start asking them about activities over the last few months, over the last few years. So what happens with clinical findings of pulmonary hypertension? When you have days to weeks of symptoms of shortness of breath, an exertion in particular, usually you're dealing with pulmonary arterial hypertension or an acute PE. So if someone was fine on the last visit 3 months ago, and all of a sudden last month they start having shortness of breath, that it's limiting, and they have to sit down, and there doesn't seem to be an acute infection, no reason to have acute heart failure exacerbations, have a pH in your differential. If it's months, that can be more like heart failure, it can be more like chronic thromboembolic pulmonary hypertension. Usually that gets diagnosed after a P has happened 3 months, and there's lung disease. One of the main critical findings is dizziness exertion when going up the stairs. So it's something you want to be asking consistently your patients about. If you have a patient who has syncope, who has angina or has palpitations, that's an emergency, because that patient most likely is dealing with a right ventricular failure, and the mortality goes incredibly high. So if someone was fine 3 months ago and all of a sudden starts developing shortness of breath, then it's acute within the last days, 2 weeks, specifically with syncope or angina or palpitations, you either send them to the ED or contact us directly for evaluation. Physical exams are usually a lab P2 on the left side with a right ventricular heave with your hand. When you have right ventricular failure, then you have some edema, hepatic congestion, elevated GVP. And you can find clubbing or sclerodactyly depending on the cause of pulmonary hypertension. So clubbing you can see with congenital heart disease, sclerodactyly with scleroderma, for example. And it's important to keep that in your differential. So how does it usually present? He'll present to you with some symptoms, rapid progressive dyspnea, as I mentioned, cannot walk on short distances. And all of a sudden we get a CT chest. And we notice that it's increased diameter greater than 33 millimeters with a specificity of 95% for pulmonary hypertension. And the ratio between the P and the aorta is also enlarged, as well as the right ventricular left ventricular relationship. Now, this is important to point out because even though we notice this happens, so from left to right, you can tell there's a normal PA to aorta ratio. And as you can tell to the right, there's an increased PA to aorta ratio. So the PA is the one on the left side, on the right side. If you look at the severe diagram, the one that's enlarged, that's the PA. If you compare it to the round artifact there, which is the aorta, you can tell that the PA is greater than 1 in terms of ratio. Now, this is suggestive of pulmonary hypertension. It's not diagnostic, but it's suggestive of pulmonary hypertension. And it should start making you think about doing more work for it. This is the difference between right ventricle and left ventricle diameters when you're dealing with someone with pulmonary hypertension as well. So after we have the suspicion with a CT with the symptoms, then we get an echo. the findings that you're looking for on an echo to diagnose pulmonary hypertension is a PSP or pulmonary arterial systolic pressure greater than 30. Sometimes it's called right ventricular systolic pressure greater than 30, an RV to LV ratio greater than 1. You can find septal flattening or RV dilation. Whenever you find any of this, in particular an echo, with clinical presentation consistent with pulmonary hypertension, make sure you send them to a PH center. This is what an echo would look like. On the right side of your diaphragm is the right ventricle on the upper chambers, and the lower chambers is the right atrium. And the left ventricle, as you can tell there, is being compressed. And the intraventricular septum is being blown into the left ventricle. So this is a patient who's got severe pulmonary hypertension, or at least severe cardiac dysfunction from pulmonary hypertension on the right ventricular dilation with paradoxical septal motion. What we do in the PH center once we receive the consult is we get all the workup. We get a cardiac MRI to assess right ventricular systolic function, we get a VQ scan to diagnose for CTEP. We always screen for CTEP, and eventually we'll get a right heart cath. This is important because when you see, this is where you guys fall in. You have a clinical presentation that's suggestive. When you send the CT chest to a pulmonary provider, it's useful, but really what you really should try to get is an echo. And with these echo findings, if the symptoms are consistent, the clinical picture is consistent, make sure to either return to a PH center or most commonly just to a general pulmonary provider. And from pulmonary providers, they can send it to us. The reason being is because, as I mentioned here, the outcomes change when these patients are referred to a specialty care center. And this has to do with how quick we can start medications. And as I mentioned before, the survival of these patients has detrimental effects on lack of therapy. So that's why we should refer them to specialty care centers sooner. So it has improved survival and fewer hospitalizations when referred to a specialty care center. And that's the reason to send it to us. Now, time to referral to a PH center from the first symptom to a PH center, that patient on average goes through 5 different general practitioners. And this is important because that means the patient was seen by someone, we can identify the shortness of breath, seen by another person, can identify shortness of breath, and so on up to an average of 5 general practitioners. And it takes a lag of about 2 to 5 years for them to finally get to a PH center. So what should we do? You get the echo. If the echo has a low probability of PH, then you can consider other causes. So if the echo doesn't show what I showed you, that echo should have a PSP greater than 30, RV or LV ratio greater than 1, then start thinking about other reasons for shortness of breath. Not that patient doesn't need to see a PH provider. But if the echo has a higher intermediate probability, let's make sure they get sent to a pulmonary provider at minimum, go to a PH center. If we have a high intermediate case, then we have to think about, does this patient have left side disease or lung disease? Again, because this is the most common findings. If you have someone who's got severe ILD and has increased pulmonary pressures, most likely this is related to severe ILD. Or if a patient has, mitral stenosis and patient has pulmonary hypertension, then most likely this is related to the mitral stenosis. Again, just by odds alone. That the patient doesn't necessarily need to go to a PH center because they don't have PAH. They do have pulmonary hypertension, but not pulmonary hypertension that needs pulmonary vasodilators. So what happens if the patient does have lung disease, but there's no signs of severe PH or right ventricular dysfunction? We treat the underlying disease. If the patient does have signs of PH or severe PH dysfunction, send them to us, and we'll coordinate with the cardiology colleagues to find out what the best treatment strategy should be. And if the patient does not have lung disease or left heart disease, then send them to us, because most of the time, maybe we can do a VQ scan, as I mentioned before, we can a right heart cath or cardiac MRI. And this is the message I want to share with you. I don't want you to feel alone in the quest of pulmonary hypertension. This is a complex disease state that requires multimodal approach and requires people who do this over and over and over again, see these patients all the time. Again, this has a high mortality rate, so we want to make sure that you feel this is only a hands away to get the help. So when do you refer to pulmonary? When you have unresolved, unexplained dyspnea, And an echo or CT are suggested for pH. And I would specify here that the echo, what we would prefer, because the CT can have multiple reasons to have dilated PA, but an echo is quite consistent. You do a workup and that fails to identify the cause, so it's not asthma, it doesn't look like COPD. If there's pH risk factors or congenital heart disease, there's suspicion for a chronic thromboembolic pulmonary hypertension. Patient that had a clot 3 months ago, persistently having shortness of breath, that's something that we should look into. There's new onset syncope, for sure, get that patient evaluated. Functional class 3 or 4, or whenever in doubt. So what do we do in a pH center? We'll try to find out the cause. We'll assess the risk of the patient, mortality risk in particular. We'll think about therapy, and then we'll do further care, including transplant and palliative care. We're fortunate to be a transplant center. So we have close relationship to our transplant folks for these patients who do require transplant. So the way we approach the cases is that we always will get a VQ scan. And if there's normal perfusion, we'll look for other causes. But if there's any mismatch, we really want to diagnose CTEP. And the reason being is because it's the only one that is curable. So from all the pH causes that I talked to you about, if there's left heart disease, well, that can be treated. If there's lung disease, depending on lung disease, that can be treated. But when it's PAH, that is a progressive, debilitating, fatal disease. So that cannot be cured. Can be treated, but cannot be cured. And when there's CTEP or chronic thromboembolic pulmonary hypertension, that can be cured. Very importantly, though, 25% of these patients never recall having a PE. So 1 out of 4 patients with CTEP won't remember having PE symptoms. So always have a high suspicion in your mind. And the reason we do a VQ scan is because this is the test that has the greatest specificity for CTEP. Let's get a CT-PE, but CT-PE will miss those chronic emboli. So what we're really looking for is perfusion defects. And that's where the VQ scan comes in. So there's a normal perfusion. We plan to do a right heart cath. And then through the right heart cath, we'll be able to classify pulmonary hypertension. Sometimes we can, sometimes we don't. And then in the pH center, we'll decide whether we give therapy to these patients or not. I'm going to walk you briefly through a right heart cath. It's an old procedure. The first person who did it on himself to get some pressures. It's relatively non-invasive. You get a catheter through one of the veins, but you just really measure pressures, come out and close like a venipuncture. You can access from multiple sites. You can do left IJ, you can do brachial axis, you can do femoral axis. And basically the catheter goes through the main veins into the right atrium, right ventricle, into the PA. Once in the PA, we inflate a little balloon, and that balloon advances to occlude the PA. And the pressure we get distal to the balloon, it's equivalent to the left atrium pressure, and that's called the wedge pressure. So this is what the traces would look like. The left diagram, you see the right atrium with a little balloon there. It's usually low pressure system. We advance the right ventricle, and you see a wide pulse pressure. And then you advance to the pulmonary artery, and then you can see, lastly, when we advance to the pulmonary arterial wedge pressure, we inflate the balloon. We measure what the left atrium information is giving us. Now, why is this important? Why am I walking you through a right heart cath? The reason is because numbers on the right heart cath are going to determine what we do with the patient, and it's going to diagnose the patient and classify the patient depending on their group. So what is a normal mean PA pressure? This report from COVAX in 2009 in the European Respiratory Journal showed that a normal mean PA for any of us is about 14. And the upper limit of normal is about 19. So, and that's irrespective of the position. As you can tell on the bottom, supine or upright. Doesn't matter if it's male or female, doesn't matter the country, it doesn't matter the age. So if you ever think about pulmonary pressures and what normal should be for a mean pulmonary pressure, it should be at the most 20. So in 1975, in the first WHO World Symposium, the limit was defined as 25 millimeters of mercury at rest. But this was empirically and arbitrarily defined. This is going to be important for all of us as a community because this has changed recently. Based on this report from Mayer in Circulation in 2016, that mean PA pressure of 25, represented with a red dot, you can tell the mortality hazard ratio increases the higher the mean PA pressure goes. But they did notice that a mean PA of 10 versus 19 had a hazard ratio of 1.1. And more importantly, between 19 to 25%, which represented 23% of the cohort, had increased 22% of adjusted mortality. That means that by diagnosing these patients of a mean PA of 25, we were missing a good chunk of these patients who had increased mortality. So that's why in the most recent guidelines last year from the European Heart Journal, the definition was changed to do a pH definition of pulmonary hypertension by mean PA greater than 20. And now we have three options when it comes to how we define pulmonary hypertension. We can say there's a pre-capillary pulmonary hypertension. We can say it's an isolated post-capillary, or it's a combined. And the numbers to remember are a mean PA of 20, a wedge of 15, and a PVR of 2. Now, I don't want you to remember this whole concept. You know, I'm not presenting this for you to remember. What I want you to remember is that because the diagnostic threshold has been lowered, we will start seeing more pulmonary hypertension patients just by virtue of diagnosis, and therefore more treatment of pulmonary hypertension. And we expect less mortality because we're treating it more consistently. What it means pre-isolated, post, and combined pre and post is depending on the wedge. So as I mentioned, the wedge, the way it's measured, it's an occlusion in the left atrial pressure. So if you have left atrial pressure increased, that's more left heart disease. And remember, left heart disease represents at least 90% of the cases. So I expect the wedge to be high. So when the wedge is not high, that's called pre-capillary pulmonary hypertension. And this is what pre-capillary present. It can be in any of the groups except group 2. Post-capillary or isolated post-capillary can present in group 2. And when we have a combination, it's all of them. And usually most of the cases do have a combination, particularly in older populations. So the patient comes to us, and what do? How do we manage these patients? Why is it important for you to refer these patients to us? We assess the patients based on risk. So if the patient has a high risk of mortality, there's the risk calculators that we use to assess 1 year, 5 year, 1 year, 3 year, and 5 year mortality. And we classify into low, intermediate, or high risk. And the goal is to have these patients on the low risk category that you can tell on the left side. You don't need to memorize these numbers, but just keep in mind that our goal is to keep these patients in low risk. Fortunately, over the last 25 years, we've had 41 randomized controlled trials to try to look for medications that can help us. And up until, truthfully, this year, there hadn't been a disease-modifying medication. We're excited about a few medications on the pipeline that are disease-modifying, because up until now, we only have vasodilators. And we hope that in the next 3 to 5 years, we'll have actually medications that will decrease the rate of pulmonary vascular remodeling. Primary outcomes on these trials have been mostly assessed through a 6-minute walk test. And this was done following the initial trial in 1996, where that was the outcome. So most of the trials have used this outcome to get approved. Most recent outcomes on combined medication in particular have used mortality as well. And they've all been positive. So we're excited about seeing a decreased trend in mortality by using these medications. This is a graph that represents a Venn diagram of what options we have for medication when it comes to oral or inhaled or subcutaneous or intravenous. So you can tell here we have a number of options now. So if a patient doesn't tolerate the medications, they unfortunately tend to not tolerate them well, just because these are hard to take medications. We always have options to switch them around. The 3 main pathways we use, as I mentioned a minute ago, are the endothelium, the prostacyclin, and nitric oxide pathway. Through the endothelium pathway, the endothelium 1 goes into the receptor, which increases vasoconstriction and proliferation. So the medications we use try to block this pathway so that we don't get as much vasoconstriction and we don't get as much proliferation. The reason to do the medication earlier is exactly this point of decreasing proliferation. When we go into prostacyclin pathway, these medications, when get stimulated, cause vasodilation. So we try to stimulate this receptor to produce more vasodilation. And that's when you see a patient in the ICU who's inhaled INO, for example. This is the pathway they're using. Or a patient goes in the hospital and needs IV therapy. This is the pathway they're using. And lastly, we have the nitric oxide pathway, which is one of the most common ones. We use it with sildenafil and tadalafil. It's important to know that they block an enzyme that breaks down the cyclic GMP, when cyclic GMP is promoting vasodilation and proliferation. So sometimes it's important to keep in mind that these are indirect pathways to help reduce vasoconstriction and increase proliferation. So sometimes they don't work sufficiently because they're not directly related to the problem. So far, we have 14 FDA-approved medications. So we have options, is what I'm telling you. We have options, and these options have increased the option we have for reducing mortality. So what is the general approach? The general approach is to treat the underlying disease. We give this patient oxygen. We want to send this patient to pulmonary rehab, and you want to have this patient on diuretics if needed. So who do we give pulmonary vasodilators to? Don't memorize this chart. Just keep in mind that this is the algorithm we go through when we see these patients in clinic. But most importantly, it's the PAH patients who really need this care. And this is important because when you see a patient who's got, again, mitral disease or grade 2 diastolic dysfunction, and you put them with sildenafil, those patients are going to get worse. So not all pulmonary hypertension needs pulmonary hypertension therapy. We need to first sort out why the patient has pulmonary hypertension. And then if the patient has pulmonary arterial hypertension, then we do testing specifically for pulmonary hypertension and then decide on therapy based on it. With contemporary therapy, this report from Marin 2021 showed that we have now a decreased mortality at 3 years from 65% to 30%. And this for pulmonary arterial hypertension. And this is a great finding for us. We're very excited to see what the future medication will bring. So what have we reviewed so far is that we're here to help. Once you see a patient with clinical presentation consistent with pulmonary hypertension, you get a CT, and the CT shows suspicion of pulmonary hypertension. You get an echo, and the echo is more consistent with the diagnosis. Send it to a pulmonary provider. And in a pulmonary provider, we'll see the general pulmonary clinic, a BQ scan, cardiac MRI, get a right heart cath. And if it's consistent with pulmonary arterial hypertension, the patient should go to a PAH center. There's a new definition for pulmonary hypertension, and this definition impacts mortality. So it's very important that we have a low threat of suspicion for pulmonary arterial hypertension. So when you see a patient like this, just think about it more often and make sure you get the help that the patient needs. And lastly, we have multiple options to treat this patient, and some coming out the pipeline, which are quite exciting. So let's go back to our patient. This is a 36-year-old lady, 50-pack history smoker, quit in 2019. 36, right? So it's very young. She had used drugs, methadone, chronic hepatitis C. So just to this, you can start thinking about stuff. 50-pack history, so smoking-related lung disease, drug abuse, maybe some hepatitis C, maybe some HIV, risk factors to get, hypertension. She now has progressive shortness of breath, has multiple ER visits. She's been diagnosed with asthma, right? Asthma, it's a low-hanging fruit diagnosis because we have therapy. So we sometimes assume everybody does have asthma, but it's important to go a little bit deeper. 20-pound weight loss, some joint pain, and now is wheelchair-bound on oxygen. This doesn't make sense, right? So we need to do a bit more work on it. Differential for this patient, it's COPD, but she's young, right? Asthma, potential, she's young. But we would have to find more information. ILD, maybe from using drugs, she can have a pollutant drug. Coronary heart failure, that could be part of the case if she has endocarditis or valvular disease. Sorry, one second, I lost. There we go. A PE, if the patient has chronic clots or acute clots, could that be infectious anemia or pH, which I want you to keep in differential. So we got a chemistry, had a high bicarb, if the creatinine was normal. ALT/AST was slightly high. A CBC normal, but she does have high hemoglobin, normal TSH and iron panel. BNP is low. She does have a positive SSB. So we're thinking about connective tissue disease at this point. PFTs have a ratio of 22, so very low. And FEV of 0.26, very low as well. She does have air trapping and DLCO. These are terrible PFTs. These PFTs are borderline compatible with life. And then she's got a CT chest. And the CT chest has a patent acid, and she does have an enlarged PA. So because she's young, we got alpha-1 antitrypsin levels, and she does have a low phenotype. So especially through the workup, gets an EF of 45%, increased PASB with dilated right ventricle. We take her for a cath, has a mean PA of 32. Now you know that means this is pulmonary hypertension with a wedge of 16. So that would be a mixed pre and post capillary pulmonary hypertension. And she's got a negative shunt study. Remember, these are numbers for the cath. So she ends up having emphysema from alpha-1 antitrypsin deficiency, but she also has group 3 PH from emphysema, group 2 PH from chronic heart disease. And is there a component of group 1 because she used drugs, because she has connective tissue disease? So we put her on prolactin C, which it's alpha-1 antitrypsin augmentation therapy. Oxygen, we started on triple inhaler therapy. Should we think about sildenafil? Is this something that we should be planning? And this is the reality of this case. Is the cases don't present just as one thing; they present a multiple causes. So we would have to keep in mind, if this patient would benefit or not from the therapy. Now she's pending insurance for transplant pulmonary rehab, and she started on sildenafil. She has improved on it. Again, this is not someone I would increase multiple medications on because she has multiple reasons to get forms of breath and the hypoxia. But I think the pulmonary hypertension, PAH, is playing a bit of a role. So lastly, I want to introduce you to the pulmonary hypertension program. Our mission is to improve the quality of life of the patients with PAH in South Texas. And this is a 3-branch way of we approaching this. Is through quality of care, patient service, education, and research. And truthfully, the way we do this is in combination with all of you. All of you are pharmacy staff, palliative care staff, critical care providers, cardiology. This is a multimodal approach because these patients are highly complex, and we need to all have a say in how these patients benefit from the program. I'm currently serving as medical director. Kimberly Winters is our liaison, is our main nurse, is coordinator, and we have 2 advanced providers, Monica and Melissa. And this program has existed for about 16 years. Dr. Levine and Dr. Malave used to be in the program. They were the founder providers a while back. So to improve the quality of life, we're working on the quality of the care that we provide through improving the process of addressing health equity, advancing testing and therapy. It may have been in the past that you're trying to refer a patient to Pulmonary Hypertension Center and it's being lagged, and we're trying to correct that. It may take a minute. We're going to try to get more support to get that to be the case. We're doing education like this, grand rounds, educating trainees, residents, and fellows. Anybody's welcome to rotate with us in the PH program. We're also doing seminars for RNs, PAs, and nurse practitioners. We also educate the families and the community at large. And we're trying to do advancement of science through PH by being part of multi-center registries now and present at different conferences. So in summary, this is a highly prevalent condition with high mortality. This mortality increases with age. It does increase with comorbidities as well. It's commonly seen in a subspecialty practice. So keep that in a high level of suspicion, both for subspecialty practice, but also in primary care providers. And we have a pulmonary hypertension center with a mission to care for all South Texas. There's a multidisciplinary team. You belong to this team. So feel free to please reach out to us, and if we can help, we're looking forward to it. And I want to leave you with this message from Jane Goodall, who cared for primates throughout her life, and says, what you do makes a difference. And you have to decide what kind of difference you want to make. So we come in and out to care for these patients, but keep in mind that days get long, but I think we also have a responsibility and the opportunity to care for these patients with knowledge now. So with that, I will stop. And I saw a question in the chat. I'm happy to address that now, and then I can take some questions from the audience. The question was, who will be a lung transplant candidate? And it's a good question. So most of the patients who have pulmonary hypertension, first they have to be sort out which type of pulmonary hypertension they have. If they have PAH, group 1 pulmonary hypertension, lung transplant candidacy comes from functional status and from therapy, meaning that if they're group 4 functional status, they cannot shower anymore, they are on oxygen at rest, and I've put her on all the medications that are available, including IV therapy, and they're still having shortness of breath, the right ventricle is still getting dilated, that's a patient that gets referred to transplant. The moment to refer them to transplant is when they have right ventricular dilation, or when they get started on IV therapy or parenteral therapy is what it's called. So that is for PAH. Something I didn't mention was group 4 or CTEPH patients. The way they get cured is by doing a surgery, but it's a very extensive, a huge surgery. It takes about 8 hours to do, and it's called pulmonary arterial endarterectomy. So they open up the chest, go through the PA artery, they cool the patient down up they cool them down because they do an arrest, they do cardiac bypass while they're doing the procedure, and they arrest the patient so that they can dissect the clot off the PA. Once the patient comes off the surgery, it's quite impressive because they've been short of breath on oxygen, on therapy, come off the surgery within hours. They're walking with no oxygen, just doing life. Some of them do have residual pulmonary hypertension, but I think knowing that there's options for therapy, it's important. And when it comes to ILD patients, in terms of the question for transplant, it's a bit different because it depends on what the ILD components are. But basically, any patient that's needing oxygen at rest that has underlying either lung disease or PAH should be referred to transplant. Second question I have here is, with the new definition of pulmonary hypertension, the PSP cutoff has changed? Good question. No, the range of PSP mean PA, which is what we're really interested in, is about 10 millimeters of mercury. So the cutoff of 30 of PSP reaches that borderline of 20 of mean PA on a cath. So because the PSP is indirectly calculated by the flow of the tricuspid valve, what we're really trying to assess is not just the PSP, but the conglomerate of findings. So right ventricular dilation, something that's called TAPSE, which is how much the tricuspid annulus is moving. Because if it's not moving a lot, that means the right ventricle is quite dilated. If the right heart is squeezing well, if the interventricular septum is moving to the left side. So it's a combination of factors. So if I have someone who has a PSP of 25, but has a right ventricular huge, I would have more suspicion. I'd send that patient for a right heart cath. Conversely, if I have someone who's got a PSP of 40, it's got normal, everything else, my suspicion for pulmonary hypertension goes a little bit lower. And that usually I'm sure you see this in practice all the time. Someone who's got a PSP 40, 45, is extremely obese, some degree of heart failure or preserved ejection fraction, maybe COPD. Those patients, unless they're having out of proportion symptoms, that PSP is somewhat expected based on what I explained, that the increased pulmonary pressures come from these other reasons, that the therapy they need is just really to treat the other reasons. So I'll pause there, see if you have any other questions I can answer. You're most welcome. So either it's more confusing or it's more clear after this presentation. But either way, thank you again for the opportunity of sharing this information with y'all. I hope this is of help. Please know that we're here to help. Usually with pulmonary in general, I think it's a good approach to when in doubt, send the pulmonary, we could sort it out. And through the pulmonary circuit, currently I'm wearing both hats of Director of Pulmonary Outpatient Services and PH Center. In a few months, I'll only do PH Center. So, we'll get those referrals for sure soon. And, remember this, a condition that is progressive and it's lethal. The mortality goes high. So we want to make sure we address it timely.
All right, any more questions or comments for Dr. Estrada before we leave? Anyone? All right, well, thank you so much, Dr. Estrada, for presenting for us today, and thank you everyone for joining, and have a good rest of your afternoon, okay?
Have a great one.
Thanks, bye.
Bye.